His current research focus is developing artificial intelligence methods for healthcare with an emphasis on leveraging longitudinal electronic health record data to enable early detection and risk prediction of complex conditions, including rare diseases. Prior to joining to the University of Tennessee, Dr. Ma earned his PhD in computer science from the University of Florida and worked as a senior data scientist at the University of Florida College of Medicine, where he developed machine learning models using real-world clinical data. So the stage is yours, Dr. Ma. Thank you.
Thank you so much, Ibrahim, for introducing me. I'll go ahead and share my screen. And thank you so much for inviting me for this presentation. I'm very glad to be here. Sorry, can you see my slide?
We can see your slide, sir.
Yeah.
Can you see my slide right now?
Yes, we can see.
Perfect. Okay, so let's get started. Hello, everyone. Welcome to this seminar. And my name is Yingbo Ma. I'm currently an assistant professor at the School of Information Sciences at the University of Tennessee, Knoxville. My talk today, the title is, Can we detect patients at risk for rare diseases earlier? A prospective deep learning study using structured electronic health records. So let's start with the background. Rare diseases are individually uncommon, but they represent a major burden for patients, families, and health systems. And hundreds of millions of people globally are estimated to have to live with a rare disease. And many of these conditions have an underlying genetic basis. However, in our routine clinical care, the path to the diagnosis is often very long and fragmented. The key reason, one of the key reasons behind this is that the early signs of rare diseases are often non-specific, which means, for example, developmental concerns, abnormal laboratory results, recurrent symptoms, and some unexplained neurological events, and unusual medical patterns. So these signals may be distributed across over years of a patient EHR history and across multiple different specialties. And for any individual clinician who sees one clinical encounter at a time, the full longitudinal pattern of this patient may be very difficult for this clinician to recognize. And that is what creates the so-called diagnostic odyssey. So patients may see multiple specialists, receive several working diagnoses, and undergo repeated testing, and sometimes receive treatments tied to a diagnosis that later proved to be incorrect. And so the clinical opportunity here is not to replace physician judgment, but to support earlier suspicion. We have genetic testing and specialty evaluation. These are increasingly powerful to formally diagnose rare diseases, but they are often ordered only after a strong clinical suspicion has been established. So the question here is whether we can use artificial intelligence to help surface the right patients earlier when the clinical signals are still very weak, but they are somehow clinically meaningful. So this is the goal of this study, and we frame the rare disease identification as a prospective prediction problem, and we use structured longitudinal EHR data before the diagnosis to identify patients at higher risks across multiple time horizons. The project is not trying to make an automated diagnosis. We're not trying to build an AI models to replace the traditional genetic testing dominated formula diagnosis, but we're not trying to replace clinical judgment. The goal is much more focused on supporting earlier risk recognition before the patient reaches the point of definitive diagnosis. And this pipeline we see here starts with a routine EHR accumulation. So every day clinical events accumulate in a structured record, and with diagnosis, laboratory results, everything. And individually, many of these events may look non-specific, but over time, they may form a pattern that could potentially suggest something more complex is happening. So our work sits at the second stage, which is risk scoring. The model, we want to train a model that can periodically evaluate a patient's longitudinal EHR history and estimate whether that patient may be at a higher risk for a rare disease. And in our study, we formulated this as a prospective prediction task, meaning that the model only uses information available before the prediction data. I'll talk about the prospective horizontal labeling strategy later. And we evaluate whether our model can identify patients before the first recorded diagnosis. And we tested this across multiple horizons, like 7 days, 30 days, 90 days, 180 days, and 365 days, which is up to 1 year before that patient actually received a formal diagnosis in our data set. And the stage 3 is clinician review. Let's say a high risk score should not be treated as a formal diagnosis. So instead, it should be treated as a prompt for clinical attention. And ideally, the system will show the clinician not only a risk score, but also the key visits or clinical events that contribute to the risk score, the high risk score. So that a clinician can decide whether that pattern is clinically meaningful. And then if the concern is clinically appropriate, then the clinician can then choose to refer this patient for genetic testing or chromosomal or exome sequencing. So the final diagnosis and care plan will still remain led by clinicians. The next question is, why do we use longitudinal EHR data? And our starting hypothesis is that rare disease often leave traces in a medical record long before the formal diagnosis is made. So these traces may not be strong enough to trigger a diagnosis in isolation. A single developmental concern or like one seizure-related visit may not be specific. But when these events are integrated or integrated together over time, they may begin to form a clinically meaningful pattern. So that is why we think longitudinal EHR is important for early prediction of the patients who have a high risk of developing rare disease. And specifically for structured EHR data, they contain multiple types of signals, diagnosis, medications, laboratory results, and procedures. So in our study, we specifically use this structured data. And clinically, each modality of these tells us something different. Like, for example, diagnosis may capture non-specific concerns, such as developmental delay. Procedures may reflect the workup process itself, such as EEGs or imaging. So the challenge here is the EHR data provide a rich, holistic overview of this patient health trajectory, but these signals are fragmented. Encounters may happen across different settings, different specialties, and visiting time is also irregular. And this is especially difficult in pediatrics and a complex care, where years of these multimodal data are compressed into a short clinical visit. So the value of artificial intelligence here in this study is recognizing the pattern that accumulates over time in one patient's EHR trajectory. And we're trying to have a model that is not looking for one magic code, instead trying to learn whether these weak and heterogeneous distributed clinical events that happen over years can somehow suggest a higher risk for rare disease. So this is why our approach treats rare disease prediction as a longitudinal modeling problem. To summarize the 3 core objectives of this project, and today's presentation will report the results for the first 2 objectives. The overarching question is whether a deep learning model trained on a structured EHR data can prospectively identify patients at risk for rare disease, and whether it can do so in a way that clinicians can interpret and potentially trust. And we broke this question into 3 objectives. The first one is to build a model that is appropriate for the structured EHR data. The patient record is not just a flat list of records, and so we need to find like somehow to organize it over time across visits, and within each visit there are also multiple types of clinical events. The second objective was to evaluate the model prospectively. So this is important because many AI models so far in rare disease detection are evaluated retrospectively. So after the diagnosis is already known. In our study, we asked a more clinically relevant question: can we have a model that identify the high risks of rare disease up to 1 year before the formal diagnosis? The third objective was to translate the model output into something clinically meaningful. For a tool like this, a risk score alone is not enough. So we probably need to design the analysis, the surface model reasoning, enrich at multiple levels, and that is a long way to go in the future. So in short, the study moves from building the model to evaluating whether it works prospectively, and then to ask whether the output can actually potentially support clinical workflow. For the data set, we use the study is built on structured electronic health records data connected to the biorepository and the integrative genomics resource at the University of Tennessee Health Science Center. And it is important because it is not just a static EHR data set. It is a growing biorepository that links both longitudinal clinical data with genomic resources. So far, across the broader big resource, more than 50,000 patients have been enrolled with their diagnosis, laboratory trajectories, medications, procedures available. Big also includes genomic sequence data for approximately 13,000 participants. We also have ongoing enrollment and sequencing of about 4,000 additional genomics every year. And for this specific study, we used a structured EHR cohort curated from big repository, and we used just over 40,000 patients, and more than the data are organized in an OMA common, which is a common data model. And there are 3 points I want to emphasize. Firstly, the cohort is pediatric dominant. It is also clinically diverse. We have with the mean age around 20 years, and we also have a substantial representation of both Black or African American and white patients. Secondly, the structured EHR is also highly multimodal. We have diagnosis, medications, procedures, etc. for each patient, for each clinical visit. And lastly, BIG creates a path beyond traditional retrospective modeling, because some participants are IRB consented for recontact. So this resource can support our future prospective validation. I just want to be quick here, like what exactly do we mean by rare disease? Because this sounds very straightforward, but in practice, there's no single universally accepted definition. Many definitions are prevalence-based. For example, in Europe, rare disease is often defined as affecting fewer than 1 in 2,000 people, while in the United States, it is often defined as affecting over fewer than 200,000 people nationally. But across clinical research, informatics studies, and health systems, these definitions are not always applied consistently. And this create a practical challenge for our EHR-based modeling research, because we're not starting with a perfectly labeled genetic registry. We're working with real-world clinical records. So diagnoses are represented through ICD-coded conditions, concept names, and also clinical documentations. So in this setting, the target phenotype has to be operationalized carefully. So as I show here in the right figure, this field often handles this by grouping rare disease into some clinically meaningful categories. This is from a scoping review of deep learning for rare disease, and it shows that the previous AI studies often focus on groups such as rare genetic diseases or neurological diseases. And this reflects how rare disease AI research it is commonly how rare disease AI research is commonly organized. So it is not always around one single disease, but around related disease families or phenotypic groups. And for our study, we follow that same practical logic. So we use a phenotype-driven, keyword-based approach, searching from ICD-coded condition names and descriptions in our EHR. And then we iteratively refine the matched concepts to de-emphasize genetically anchored conditions. So the key point here is that rare disease in our study is not treated as one homogeneous condition. It is constructed from clinically meaningful rare disease categories, and with our goal of identifying patients who may warrant earlier specialty or genetic evaluation. So using our keyword-based phenotype definition, we identified about 8.3% of the patients in our study who carry at least one diagnosis, matching our curated rare disease keyword set. So the largest group in our cohort was neurological and epilepsy-related disorders, with just over 1,000 patients. And this is followed by chromosomal and genetic disorders, and then neurodevelopmental disorders. And this one point I want to emphasize is that these categories are not meant to be perfectly isolated to each other. So a patient can absolutely appear in more than one category if the clinical record reflects overlapping disease processes. So for example, a child with a chromosomal syndrome may also have epilepsy or developmental delay. So this slide is important that in terms of explaining our multi-horizon prospective labeling. And it's, so basically, in many EHR-based studies, the model is evaluated retrospectively, which means the model may be trained or tested using information that is very close to, or sometimes after the formal diagnosis has been already clinically established. And for rare disease, that is not a clinical problem we're trying to solve in this study. And the real question is whether we can identify high risk before the diagnosis is formally recorded. So we use a multi-horizon prospective labeling strategy. And for each patient with a qualifying rare disease diagnosis, we have the first diagnosis date, and we identify the first recorded diagnosis date in our data set. And then we move backward in time and define an index date at different times, like 7, 30, 90, 180, and up to 1 year before that first diagnosis. And at each horizon, the model is only allowed to use the EHR data observed before the index date. So, which means anything after that point is hidden from the model. So the model cannot use that information when it comes to training. So this is critical because it prevents temporal leakage and makes the evaluation closer to a real clinical deployment setting. Another point here I want to explain is the reason why we use multiple horizons is that prediction 1 year ahead and predicting 1 year ahead and predicting 1 week ahead are not the same clinical task. A 7-day prediction may support near-term or expedited review, but an up to 1 year prediction is more like early screening or risk stratification. So this design also lets us allow us to ask a clinically meaningful question: is how early does our model begin to see a meaningful signal? As expected, prediction will become harder as we move further away from the first diagnosis date. So okay, so this slide gives an overview of our full modeling pipeline. The main idea is that we represent each patient as a longitudinal sequence of visits, and each visit contains a set of structured clinical events, including diagnosis, labs, medications, and procedures. And starting from on the left, we first constructed a patient timeline from the structured EHR. And for each patient, all clinical visits are ordered chronologically. And within each visit, we collected the multimodal clinical events recorded in a database. And this allows us to represent the patient history not as one static snapshot, but as an evolving clinical trajectory over time. And the second part is within visit aggregation. And this is important because the clinical events inside a single clinical visit, they do not have a natural sequence. Although they are recorded, they have their time step. However, for example, during one encounter, a patient may have a diagnosis code, several lab results, medication orders, and procedures. So the order in which these appear in the EPIC system, in our current database, is often administrative, not clinically meaningful, and they contain much noise. So instead of forcing these events into a temporal sequence, we treat these events within each clinical visit as an unordered set. And each event then is represented using 3 types of embeddings: a modality embedding, which tells the model whether the event is a diagnosis, a lab, a medication, or procedure. We also have a concept embedding, which captures the clinical concept itself. And for laboratory measurements, we also have a value embedding that captures the lab value. Then we use multi-query attention to summarize the events within a visit. And rather than averaging all clinical events equally, the model will learn multiple queries vectors, and each query can attend to different clinical patterns within a single clinical visit. And one query may focus more on laboratory results, like abnormal lab results. Another query may focus more on neurological diagnosis. The output is then a fixed length visit representation that preserves multiple phenotypic perspectives from that encounter, extracted from these queries. And this is especially important because for rare disease prediction, the signal is often heterogeneous and may not come from one single data type. The third panel, the third part is across visit temporal modeling. And once we use multi-query attention to convert each clinical visit into a fixed embedding, then we model the sequence of visit over time using by in a traditional fashion, like with transformer encoder. We also specifically added a temporal context, including this patient age at each clinical visit, as well as the time gap between visits, like how many days are between each two clinical visits. So this also matters clinically because disease progression may unfold over months or years. So the changes in clinical visit frequency themselves can also reflect the increasing concern. So the transformer then learns the temporal dependencies across each clinical visit. So earlier laboratory results or repeated symptoms can be interpreted together as part of one longitudinal trajectory. And after that, the model produces a patient-level risk score between 0 and 1 for a given prediction horizon. For example, the model may estimate whether this patient is at high risk before the first diagnosis, depending on the horizon-specific task. Let's say, for example, the prediction score is 0.89, then this patient will be screened to the top high risk group. And finally, we designed this framework to support clinical interpretability. So we examine attention patterns across clinical domains, identify event level tokens, and we also visualize the visit level importance along the patient timeline, which I will show these three level clinical interpretation in a later slide. So in one word, the key methodological contribution here is the hierarchical two-level structure. First, we model events within each clinical visit as an unordered set, and then the visits across time will be modeled as a sequence. This is one of the most boring slide in this presentation, which is the prospective prediction performance. I'll go through this very, very quick. The key result is that our model produced the highest AURC and AUPRC at every prediction horizon against strong baseline models. And for this task, I want to emphasize that AUPRC in particular, because AUPRC is useful for measuring overall discrimination. AUROC is useful for measuring the overall discrimination, but in rare disease context, the positive class is very rare. So in our cohort the prevalence rate ranges from 4.6% at 7 days to about 3.3% at 365 days. So in this kind of imbalanced setting, the AOPRC is more clinically informative. And if we look across the table, the performance of our model is strongest close to the diagnosis, which is expected. As at 7 days prediction horizon, the model achieved an AOPRC of 0.57. And if we move further away from diagnosis, the task becomes harder, and because the clinical signals are now weaker and less explicit. But even at 365 days, which is up to 1 year ahead of before the formal diagnosis, the model still achieves an AOPRC of 0.255. So compared to the prevalence baseline of only 3.32%. So clinically, the most important finding is that the advantage of our model is largest at the longest horizon. And as you can see, at 365 days, the AUPRC improvement over the strongest baseline is the positive of 0.04. And that is exactly where the problem is hardest and potentially most useful. Now we have seen the predicted performance. Next question is whether the model is learning some clinically meaningful patterns, or whether it is simply producing a score that is difficult to understand. This slide shows one way we examine clinical interpretability, which is by showing the query specialization heat map. So remember, in our model, each clinical visit was summarized using queries. And now, as shown in this figure, we had 8 queries in total, and these queries are not manually assigned to each clinical categories, and they were learned during the model training. And after training, we can examine where each query places its attention across 4 clinical domains. And from this figure, each panel corresponds to a different prediction horizon. From left to right, it shows from 7 days to 365 days before diagnosis. There are 2 important takeaways here. The first is the model does not rely on a single data modality. And across horizons, different queries attend to different mixtures of diagnosis, labs, medications, and procedures. And this is clinically important because rare disease signals are indeed usually multimodal, and a patient may have non-specific diagnosis and repeated abnormal labs, and diagnostic procedures that only become meaningful when clinicians consider them together. And the second thing is that the attention pattern changes across time in a clinically reasonable way. If you look at a shorter horizon, we see that the diagnosis-related and treatment-related signals contribute more strongly to the model's final prediction. And that makes sense because close to diagnosis, the clinical picture is more clear and explicit. The patient will have more rare disease related diagnosis. And for example, and also coded rare disease related diagnosis or anti-epileptic medications. However, if you look at the rightist panel, which is the longest horizon of 365 days, the model places more emphasis on laboratory results and procedure-related signals. And this suggests that earlier in the trajectory, the model was picking up biological abnormals and before the final diagnostic label appear. Clinically, this is encouraging because it aligns with how the diagnostic suspicion often develops. And early disease may appear as abnormal laboratory results or repeated testing, and later in a shorter prediction horizon, it becomes more explicit because the patient will have more rare disease related diagnosis code and treatment patterns. I'll still be careful here because attention is not proof of causality, but as a descriptive window into model behavior, this analysis suggests that the model is learning a stage or a horizon-dependent patterns that are consistent with the current rare disease diagnostic pathway. And this slide moves from the domain level interpretation to event level interpretation. And on the previous slide, we saw that the model shifted attention across diagnosis, labs, medication procedures, depending on the prediction horizon. And here we ask a more a clinically concrete question, which is which specific clinical events are enriched among patients that the model assigns to the high-risk group. So to do this, we compare the frequency of individual clinical events between patients with high-risk predictions and the patient with low-risk predictions. And the figure here shows the top enriched events at two very different horizons. The left is 7 days and before the diagnosis, and the 365 days before diagnosis on the right. The contrast between these two panels is interesting and clinically important. At the seven-day prediction horizon on the left side, the events read include much more like the late diagnostic workup itself, and we see terms such as status epilepticus and intractable complex partial epilepsy. So these are signals that may already reflect a patient who is very close to a formal recognition or diagnosis of a rare disease. And at the 365-day horizon on the right side, the pattern is different, and we see that the enriched clinical events shift toward like earlier biological and biological signals, and also like some medications and functional MRI. So these do not simply look like the final diagnosis label for a rare disease. They look more like the earlier metabolic or neurologic evaluation. So this is important. This slide is important because it supports the idea that our model was not just memorizing those obvious rare disease diagnoses. And at the longer horizon, the model appeared to be able to capture patterns that are consistent with pre-diagnostic evaluations. And again, we should interpret this very carefully because these odds ratios are not, again, causality explanations. And they do not mean that any single lab or procedure should automatically trigger a diagnosis. But if we combine this one and the previous heat map together, they provide clinical validity. So our model's high-risk predictions are associated with events that make sense within the rare disease diagnostic pathway. And this slide shows a patient-level clinical interpretation, which is a true positive case of Angelman syndrome. And we used the 365-day prediction horizon. And the important point is that at the 365-day horizon, which the model was making a prediction 1 year before the first formal diagnosis date. And then here I have the shaded gray area on the right. And this shows that the events that occur after the 365-day prediction horizon. From this patient, the first documented Angelman syndrome diagnosis happened on April 18th, 2019. But 1 year earlier, using only data available before that point, our model already assigned a high predicted probability of 0.809. And as the patient moved closer to diagnosis, the predicted probability increased further, as we can see, 0.913 at 100 days, 0.985 at 90 and 30 days, and 0.99 at 7 days. And clinically, this timeline is also meaningful because earlier in the record, we see repeated hearing-related concerns. The very early stage, the the patient received like hearing loss related diagnosis, and also visual reinforcement audiometry. And later, the record begins to show more neurological events, including the first seizure episode and then recurrent seizures. And after the 365-day window, then the chart continues to evolve toward epilepsy diagnosis, EEG monitoring, and a chromosomal deletion, and eventually an Angelman syndrome. And on the top, the panel A, it shows the visit level attention weights from the 365-day model. And we can see the model does not attend or places its attention uniformly to every clinical event. So instead, attention concentrated on several clinical encounters, especially around those confirmed hearing loss and the first diagnosis of seizure. And panel B on the bottom aligns that top clinical concepts across the patient timeline by diagnosis, medication, laboratory, and procedure. So this is the type of the output that could be potentially be useful in the future clinical decision support setting. And rather than simply showing a black box risk score, if we can have a system showing to our clinicians a longitudinal risk trajectory and the key visits contributing to the concern, that will be better. So the key takeaway from this slide is that our model's prediction was not based on the final diagnosis label. It is based on earlier distributed clinical signals that also appear clinically coherent, I'll say, when reviewed by our clinicians longitudinally. And now I'll summarize the three main findings from this study. The first one is our model showed a very robust prospective performance across all 5 prediction horizons. It achieved the highest AUPRC before the first recorded diagnosis, and this is important because the task becomes progressively harder as we move further away from the first confirmed diagnosis. The fact that the largest performance improvement over the strongest baseline occurred at the 365-day horizon suggested that the model design is especially useful in a long horizon setting where the early recognition matters most clinically. The second point is our clinical interpretability analysis were clinically coherent. So we saw a temporal shift in what our model used across different horizons. At shorter horizon, for example, 7 days, the predictions were more influenced by diagnosis and treatment-related clinical events. And at longer horizons, which, for example, 365 days, the model increasingly used laboratory results and procedure-related signals. And clinically, that also makes sense because earlier patients may have non-specific symptoms or abnormal lab results. And later, those concerns will become more explicitly coded as a diagnosis or like treatment patterns. And so this suggests that the model is not simply detecting the final diagnosis label, but also learning horizon or stage or prediction horizon dependent patterns in the diagnostic trajectory. The last one is the model has potential as an upstream risk stratification tool. If you recall those 5 steps, and we see this study is in the second step for the earlier risk screening. So we think the model has the potential to serve as an upstream risk stratification tool, because especially at the 365-day horizon, it achieved an EOPRC of 0.255 against a prevalence baseline of about 3.3%, which is approximately eightfold enrichment over baseline. Importantly, this does not mean that the model is ready to make diagnosis. And instead, it suggests that the model could potentially help clinicians to prioritize patients for earlier review, referral, or genetic evaluation during the pre-diagnostic window. So the overall message is that the structured EHR data, they do appear to contain clinically meaningful signals, pre-diagnostic signals, and could be, and by using a carefully designed model with artificial intelligence, it can help surface those signals earlier. Limitations and next steps. I want to be very clear, and because they directly define our next steps toward clinical translation, which is longer way to go. The first limitation is that it's very, unfortunately, this is a single site cohort and pediatric dominant, and the data come from one academic medical center, and the cohort is toward pediatric patients. So this is appropriate for many rare disease use cases, but it also means we cannot assume that the same model will generalize to adult populations or different community settings or institutions with different coding practices or referral pathways. So the external validation is our immediate next step. The second limitation is label noise. Because we use the outcome on the first qualifying ICD coded diagnosis in HR to define to identify the positive patients with rare disease. But clinically, we also know that the moment of suspicion may occur much earlier than a coded diagnosis, and some patients may have undiagnosed rare disease without ever receiving the relevant code. So the labels are all they're imperfect, and this will inevitably introduce the noise in the model training, and also means that our measured lead time is somehow conservative. So future work with like genomic confirmation or curated chart review will probably provide a stronger ground truth for our future studies. The last limitation is that we use structured EHR data only, and we use diagnosis, labs, medications, procedures. These are valuable, but a lot of early clinical reasoning also lives in clinical notes or image reports. Those data were not included here, and we were thinking to include all of these information as our natural next step. And finally, this is not a prospective deployment study. The results are retrospective on held up data, and we have not tested how clinicians respond to risk alerts, whether alert can change referral behavior, or whether they improve time to diagnosis. So the next phase will include external validation and better labeling tactics, multimodal data integration, including clinical notes and images, and eventually a prospective clinical evaluation. So that's the end of the story, and I appreciate everyone to be here today. And thank you so much for your time. And your questions are very much welcome now. Thank you.
Dr. Mo, thank you very much for this wonderful presentation. I am Dr. Demir from Care Center. Dr. Ibrahim had to leave early, so I will be helping you during the QA session. Dear participants, all of you, you may ask your questions by turning on your microphone or raising your virtual hand or using the chat part. If you want to ask, yeah, Dr. Abbas. We can't hear you.
Can you hear me?
Right now, a little.
What about now? Can you hear me, guys? Hello,
Yeah,
hello.
right now it's good.
Okay, Dr. Ma, thank you so much for the awesome presentation. I really enjoyed the work. I am from the AI modeling and solutions unit, and like it was very interesting work to see. I have two questions. The first one was about did you stick within the already standard data format, let's say ways like the MEDS or I2V2, or you just come up with a different way in terms of the pre-processing of the data?
Oh, because the data is already in the OMAP formal standard.
Oh, you just relied on that one and did the pre-processing, right?
No, it does not require too much pre-processing steps. So because this cohort has been carefully managed for years, and it started accepting patient records starting from 2014, and it's still until now and still updating annually. And they have a data analytics team to process the data and curate the OMA format for you. So for me, I just register my IRB, get the data access, and just do my AI modeling work.
Gotcha. Thank you so much.
Yeah.
If Dr. Gurkhan, I have one more question, but the time limitation is considered.
Please go ahead. Yes.
Yeah. Just about the one more question from the clinical perspective. So about the like clinicians concordance in terms of the labeling that, okay, this patient has this specific, let's say disease. How much concordance rate did you achieve? Or it was just like one person and you were sure that there's a, that genetic disease already and you were sure about that one?
Unfortunately, we only rely on the first coded diagnosis in our EHR data, which first of all, the coded label, also the timeline is noisy. Nobody can guarantee that is the accurate. Second of all, there are patients who are having rare disease, but they never receive a clear diagnosis. So this is related to what I talked about, the label noise, to like when we use artificial intelligence for rare disease prediction. It is actually an open research challenge, how to deal with the label noise for rare disease.
Gotcha. Thank you so much. Good luck. Thank you.
Yeah, thank you so much. Yeah, thanks for the question.
Dr. Gurjan, please. You can
Yes,
continue.
Dr. Ma, thank you so much. This was a really great presentation. Just, I
You're welcome.
really
Thank you.
enjoyed it. In one of your early slides, you had these different steps, and then you had marked this particular talk as step number 2. I wonder if we can go back to that slide,
Yes, absolutely.
please.
This one.
Yes, just
Yeah.
Can
you tell us a little bit about the other steps and how this step will impact the other steps and the challenges, and just it's going to be really helpful.
Oh yeah, so this is the step that we envision if this could serve as an upstream risk stratification tool. Which step can it be integrated into clinical workflow, and how it can support earlier genetic referral to diagnose rare disease. So the important thing is it is not trying to make a diagnosis, and it's not trying to replace clinical judgment. It's just to support earlier risk recognition. And if the stage one is it starts with the accumulation of EHR, and then if you remember like that visit chronological, that patient level, that case study. So if we can if we have an AI system that receives those EHR data every month, and we can somehow visualize this patient's trajectory for the risk elevation for rare disease, and then it can produce a continuous risk score for each patient, and then this score can directly go to the clinician's desktop for the stage 3 clinician review. And then it's totally up to the clinician by reviewing the risk score, the flag patients, and also based on as you see, like the interpretation, like what are the important clinical events happened before that contributes to the flag for this patient. And then it's up to this clinician's decision whether this patient should be referred for the next step genetic evaluation or not. And once the genetic referral is ordered, complete the target testing, and then it will support the final diagnosis here for this patient for rare disease confirmation. Still, this is we envision this as a 5-stage flow, and this tool could be placed as an upstream risk stratification tool if it can be integrated into the clinical workflow. But still, I would say this is a very early stage design or our thought of how this system can be useful.
Oh,
Yes.
this is excellent. Just of course, when these systems are deployed, the rest of these stages may need to be changed, right? Because there may not be enough genetic counselors, or the labs works may not be sufficient to be able to absorb all these, because many of these risks currently go undetected. People don't get tested. So as a result, probably when these AI systems are deployed, it will have a lot of implications for the rest of the health system. Is that what you're thinking too?
Yes. For example, like the data may not, for example, right now we think, oh, like if we can accumulate the data, and what it may happen in real clinical workflow that some of the EHR data is not synchronized, or it may not be recorded, and some clinical notes coming much later than what the procedure actually happened.
Yeah.
So there are a lot of things that needs to be changed upstream and downstream if we integrate this in a clinical workflow. But we have encouraging results from this study. This study is purely focusing on the AI modeling and to ask the question that whether longitudinal structured EHR is useful, and can we potentially have an AI model that can predict the risk up to 1 year ahead of the formal diagnosis.
Oh, that's wonderful. Thank you so much. We really appreciate your participation in our AI seminar series. This month we have a treat. Typically we have a single seminar, but because next week we are celebrating Nurses Week, we have a special AI seminar specifically talking about nursing AI. And for those of you who are still with us, if you're interested, we would encourage you to register for the May 11th nursing AIIA seminar series at noon. Thank you very much, Dr. Ma, again, and thank you very much, everybody. Have a nice afternoon. Bye-bye.
Thank you. Bye-bye.